A good day to all, third year. So today we are now talking on the disorders of the eyes. So we will start out with the eye disorders with the topic under refractive errors. So we'll start this now. So we'll talk about the first term that we have here, which is emetropia. This is how we describe normal vision. Those who have 20/20 vision. So persons for whom the visual image focuses precisely on the macula and they do not need eyeglasses or any contact lenses. So if any of you are not yet using eyeglasses, you are emetropic. So it means that your eyesight, your vision is good. It's normal, unlike some of us. Next, we have this one. In refractive errors, vision is impaired because a shortened or elongated eyeball prevents the light rays from focusing sharply on the retina. So there is an irregularity on the patient's eyeball, making it hard for the patient to focus depending on the eyeball irregularity that the patient has. Now we start out with myopia. Myopia is also known as nearsightedness. When we say nearsightedness, I am one of those persons who have this myopia. My eye disorder, my eye condition is a mixture of myopia and astigmatism, which I'm going to describe later on. And I'm pretty sure some of you have this as well. For nearsighted people like me, we are able to focus objects that are near to us. But for objects that are far away from us, they would appear blurry. Like, for example, if I am going to watch a movie at the cinema, I always need my eyeglasses with me, or else the the movie that I am going to watch will appear blurry for me. There was a certain time when I forgot to bring with me my eyeglasses, and I didn't enjoy the whole movie because the whole movie was blurry. So that's one of the problems that we myopic people have. We have problem focusing on far objects due to elongated and deeper eyeballs. I have an anecdote with regards to this. When I was coming home, I was not wearing my glasses at that time. I was coming home from work, and I was teasing someone from far away in front of the house of my cousin, and I thought it was my female cousin that I was teasing far while I was far away, and I was approaching their house because their house is situated in front of our house, so I need to pass through it. But when I got near to that person I was teasing from far away, I realized that it wasn't my cousin. So it was an embarrassing moment for me since I wasn't wearing my eyeglasses at that time. So that's a problem for people like us, myopic. So the image focuses in front of the retina instead. So people experience blurred distant vision. So objects that are far away, distant from you, you are going to experience that. And usually we use biconcave lenses to correct myopia. Next, we have hyperopia, also known as farsightedness. So this is the opposite of myopia. So this is due to shallow or short eyeball. My mother has this because when she is texting or sending a message, she reads her cell phone like this. She is going to use her phone far away from her face. in order for her to read the messages that she has. So if you have any parent like that, or if you know someone using their cell phone like that, they are using their phone as far away from their face as possible without their glasses in order for them to read the messages or browse through social networking sites, then they probably have hyperopia. So the visual fall beyond the retina now with this problem. And if people experience blurred near vision, that's why they are, for those using phones, they are keeping it away from their face because if they keep it near their face, they are going to experience this blurred vision. And the type of lenses used by hyperopic people would be biconcave lenses. So this is how ophthalmologists correct hyperopia by using biconcave lens. Now here, this is the one I was mentioning earlier because my eye problem has a mixture of astigmatism. This first started out when I was in late high school or college, I think early college, and I didn't have myopia yet. It developed later on in life, but this one is the first one that developed in me, astigmatism. So it's caused by irregular curvature of the cornea. So there is an irregularity in my cornea, which results in distortion of visual image. And because of this distortion, one of the things that a person with astigmatism might feel would be headaches. And I was experiencing that before due to my astigmatism. So there's nothing wrong with the shape of the eye. The problem lies with the cornea itself. So, in order to correct astigmatism, the usage of cylindrical lenses is needed by persons who have this type of eye disorder. So, my eyeglasses is a mixture of being a cylindrical and a biconcave lens in order to correct my eye problem. Treatment, there can be other treatments other than wearing eyeglasses, such as LASIK. LASIK stands for laser assisted in situ keratomiliosis, and it is used to reduce the dependency of the eye to eyeglasses or contact lenses. So, for those who are not used to wearing eyeglasses or contact lenses, this would be the treatment of choice for you, since it permanently changes the shape of the cornea using a special laser, thus focusing exactly at the retina. So, LASIK can be one of the treatments of astigmatism. Now we go to low vision and blindness. Low vision is defined as best corrected by visual acuity or BCVA of around 2070 or 2200 visual acuity. So it's a general term used to describe vision impairment that requires devices and strategies in addition to corrective lenses to perform visual tasks. That's why it's very, very important for you to have your visual acuity assessed in order to determine whether you need glasses, corrective lenses, or not. Most especially if you need your eyes in doing your work. Let's say, for example, you are driving a car or a truck. If you are not wearing corrective lenses, that can be a problem later on. That is why one of the things they are asking at the Land Transportation Office is if you are having visual problems or not, because you need to be very honest with this because you are putting your life at stake when driving without corrective lenses. That's why if you are driving and you know that you have a low vision, you have problems with your visual acuity, then you need to wear corrective lenses in order to perform visual tasks. Or let's say, for example, like right now, most of the things that we rely on, especially you students, would be technology, the use of laptops, your phones, and so on, in order for you to study. Of course, you need corrective lenses in order for you to do your everyday tasks as a student. Now, for blindness, this is defined as BCVA that can range from 2400. So 2400. And with this, uh, if you have absolute blindness, this is absence of light perception. Or this one, 20 to 2400 to no light perception at all. But for legal blindness, this is having a BCVA of 2200 in the better eye. So if you have a visual acuity of 2200, you are already considered legally blind. You need to have corrective lenses in order for you to see, in order for you to perform your everyday tasks. Causes of having blindness. It's for among adults 40 years or older, the visual acuity becomes poor as we grow older, or probably due to diabetic retinopathy or macular degeneration. So the macula of the eye as we grow older degenerates due to aging, or the development of glaucoma, which we have a different lecture for that, together with the formation of cataracts. Medical management is our goal is to optimize the patient's remaining vision and assist the client to perform customary activities or their activities of daily living. They need corrective glasses or lenses in order for them to perform these things. So they need low vision aids, strategies, and referrals to social agencies if needed, optical devices like this, glasses, retinal implants, or artificial retina can be used by the patient. Nursing management, we need to promote coping efforts for this patient. They need to cope with having or wearing eyeglasses or contact lenses in order for them to perform their everyday or their activities of daily living. Promote spatial orientation as well, what like the use of a clock so that they know the time, and make sure that the furniture at home remains in the same position. Do not change anything in the patient's home. It is very vital that the patient's furniture remains at the same position in order for them to know where to go and avoid any accidents that might happen in the future. And when you're entering the patient's room, introduce yourself and alert them when you're going to leave. Provide physical assistance, encourage independence, and ensure safety as well. That's why in the house of the patient, it's most advisable for the patient probably to wear glasses while going up and down the stairs in order to prevent any accidents that might happen. Promote home and community based care as well. Now we go to glaucoma. It is used to refer to a group of ocular conditions characterized by optic nerve damage. And in the past, it was seen more as a condition of elevated intraocular pressure. IOP means intraocular pressure, than optic neuropathy. So here, the optic nerve is already being damaged in glaucoma. If you well know about history, especially that of Dr. Jose Rizal, glaucoma is the eye disorder of Teodora Alonso, the mother of Jose Rizal. That's why he went and studied medicine in order to treat his mother's glaucoma. Causes of glaucoma can be the following: diabetes, uveitis. So there's an inflammation that is happening in the inner eye, or retinal detachment. Retinal detachment can happen due to accidents on the patient's head. We have a different topic for that as well. Now, the pathophysiology in glaucoma, this happens when the aqueous fluid drainage is blocked. And if that is blocked, pressure builds up in the eyes. So, theory here why there is blockage of fluid, aqueous fluid drainage is due to direct mechanical theory. There's high intraocular pressure leading to the damage in the retinal layer of the inner eye, or indirect ischemic theory. There's the high IOP compresses the microcirculation of the optic nerve head. That's why the optic nerve is also involved. That's why it leads later on to the damage to the optic nerve due to the high intraocular pressure. So imagine our eyes is like a balloon, and that balloon you place too much um, water in it because our eyes primarily is made up of water. If there's too much fluid inside it, it will cause pressure on the either the retina or the optic nerve. Of course, further impairing the patient's vision. And we have classification of glaucoma. We have number one, open angle glaucoma. It's usually bilateral, so it involves both eyes. But one eye may be severely affected than the other. And the anterior chamber angle is open and it appears normal. So we have primary open angle glaucoma. There is normal tension glaucoma and ocular hypertension happening, while another with increased IOP, optic nerve damage, and visual field defects. So, since there is an increased intraocular pressure, this will further damage either the retina or the optic nerve. So, the normal tension glaucoma, it has a normal IOP, but there is optic nerve damage with visual field defects. Now, for ocular hypertension, there's elevated IOP, and the patient is going to feel ocular pain together with headaches. Number two, the angle closure or pupillary block glaucoma. So this now causes there is an obstruction in the aqueous humor outflow due to complete or partial closure of the angle. That is why the fluid is building up inside the eyes due to the closure of the angle from the forward shift of the peripheral iris to the trabeculae. So if it is closed, the aqueous humor cannot be drained, further increasing the intraocular pressure of the patient. So for acute angle closure, this is an ocular emergency due to rapidly progressive visual impairment, and the IOP severely elevated. And you can see that there is a corneal edema. For chronic angle closure, IOP may be normal or elevated, and there is progressive visual field loss. Now, assessment and diagnostics. Tonometry is the one that is used to measure the intraocular pressure. Ophthalmoscopy is used to inspect the optic nerve. Gonioscopy is used to examine the filtration angle of the interior chamber. Perimetry used to assess the visual fields. But this is no longer a job. This is the job of the ophthalmologists. They are going to, these doctors or these specialist doctors will be the ones to measure these things, not us. And if upon observation of the ophthalmologist, they can see that there's cupping and pallor of the optic nerve disc. Cupping is characterized by exaggerated bending of the blood vessels as they cross into the optic disc. The cup appears more basin-like, and increased pallor is due to the loss of blood supply. And the patient is going to experience scotomas, such as in this picture. That is an example of a scotoma. They still have the visual field, but in their visual field, there are localized areas of visual loss, like this picture that you can see here. Now, other signs and symptoms, the first thing that is going to disappear from the patient's field of vision would be the peripheral vision. That's why they can only see um, people or objects in their midline. So that's known as tunnel vision. They have tunnel vision. Their peripheral vision is lost. That's why if you are going to approach them from their sides, the patient is not going to see you. You need to talk to the patient, or you need to talk in front of the patient, not on their sides, because they won't be able to see you. Now we go to the pharmacologic therapy for glaucoma. First, we have cholinergics such as miotics, pilocarpine or carbachol. This will increase aqueous fluid outflow by contracting ciliary muscle and causing meiosis. Meiosis is constriction of the pupil, since pupil dilation will further close the angle, causing increased IOP. So this will open the trabecular meshwork in order to drain the excessive aqueous humor that has built up. Caution patients about diminished vision in dimly lit areas. Adrenergic agonists such as dipivefrin or epinephrine. This reduces production of aqueous humor and increases outflow as well. We need to teach patients about punctual occlusion to limit systemic effects. Systemic effects can cause palpitation, elevated BP, tremors, and headache. So we need to teach about these side effects to the patient, since these are sympathomimetics. When we say sympathomimetics, these are drugs that mimic or imitate the effects of sympathetic nervous system stimulation. Remember, if the sympathetic nervous system is stimulated, all of the vital signs are increased. That's why these things will occur: elevated BP, palpitation, and so on. Beta blockers, such as betaxolol and timolol. This will decrease aqueous humor production. Again, teach patients about punctal occlusion to limit systemic effects. Same as that of the systemic effects are opposite of that of the adrenergic agonists, since they will cause bradycardia, hypotension, and exacerbation of any pulmonary disease if there is, such as asthma. Next, we go to alpha adrenergic agonists, apraconidine and brimonidine. This decreases again aqueous humor production. Again, the same thing. The side effects would be similar to the adrenergic agonists here: palpitation, elevated BP, tremors, and headaches. Now we go to the carbonic anhydrase inhibitors such as acetazolamide, metazolamide, and dorzolamide. Again, the same action, decreasing the aqueous humor. We need to monitor the patient's electrolyte levels. And this is contraindicated to patients who have sulfa allergies, such as if they are, for example, allergic to sulfonamides, which is an antibiotic, these things will not, or these drugs will not be given to that patient. Now we go to prostaglandin analogs such as latanoprost and bimatoprost. This will increase the uveoscleral outflow of the aqueous humor, so it will drain the aqueous humor from the eye. Implication is conjunctival redness and darkening of the iris. So you need to warn the patients about those if those things happen. Surgical management would be laser trabeculoplasty. A doctor is going to apply laser burns on the inner surface of the trabecular meshwork in order to open them and widen the canal of Schlemm, therefore promoting outflow of aqueous humor and decreasing the IOP. Since um, there is an increased IOP due to the closure of the trabecular meshwork, this will make the trabecular meshwork open to increase the outflow of the aqueous humor. Laser trabeculoplasty is indicated when medication for or medications can no longer control the increased intracranial or intraocular pressure, and it's contraindicated in narrow angle glaucoma. Complications of this procedure would be transient increase in IOP 2 hours post-op. That's why the doctors need to assess the IOP post-op every 15 minutes and so on. Another is laser iridotomy. It's an opening made in the iris, as you can see here, in order to eliminate the pupillary block. So since there's a blockage there, they'll create an opening in order again to drain the aqueous humor. But it's contraindicated for patients who have corneal edema, which interferes with laser targeting and strength. Pilocarpine is prescribed to prevent the closure of the iridotomy. So after the doctor has done laser iridotomy on the patient, pilocarpine is given afterwards or post-op. So that's it for glaucoma. Next, we have cataracts. Cataracts are characterized by lens opacity or cloudiness, and they are common in old people, in the elderly. Can develop in one or both eyes, and you, like what I've said, this is occurring in the elderly, usually age related, but you can be due to ocular conditions, toxins, nutrition, physical factors, systemic diseases, or syndromes. Clinical manifestation, there's painless blurring of vision. And you can see that the patient can see that the surroundings appear dimmer. Astigmatism, diplopia, and brunescence may be experienced by the patient with cataract. So in brunescence, this is the discoloration of the nucleus in cataract that occurs as the nucleus becomes more sclerotic. And it will appear or it will begin as yellowish first and it further progresses to orange until it becomes brown. Surgical management, we have either intracapsular cataract extraction or extracapsular cataract extraction. I have assisted in these types of surgeries before, ICCE or ECCE. And usually, after they remove the cataract from the patient, that is together with the lens, the doctor is also going to remove the lens from the patient. The lens will be replaced, and they will perform after ICCE or ECCE is done. Intraocular lens implant will be performed by the ophthalmologist. So as you can see here, they will create an incision there on the eye and place an artificial lens on it, suture it again, and allow it to heal within the next few weeks. And that IOL is an artificial lens made of silicone or acrylic placed within the eye when the natural lens of the eye is removed. And it's most often used for cataract patients. I have assisted in this type of surgery before, and the type of instruments that are being used for eye surgeries are very small. They are minute. And usually these type of surgeries, they are done as OPD. It's not a major type of surgery, it's just a minor type of surgery. It's OPD. Another surgical procedure in cataract would be doing phacoemulsification. During phacoemulsification, a surgeon makes a small incision at the edge of the cornea. So similar to ICCA and ECCA with IOL implants, but instead of removing the lens, they are going to insert. So they're going to make a small incision at the edge of the cornea and then create an opening in the membrane that surrounds the lens. And they're going to insert a small ultrasonic probe, which will break up the cloudy lens into tiny fragments. That's how phacoemulsification is done. Now, for aphakic glasses, these are eyeglasses prescribed after cataract surgery if no intraocular lens is inserted into the eye. But this is no longer a common practice now. And usually these are thick convex lenses, as you can see here on this picture. This is no longer applied because when I was still a young nurse, I saw when I assisted in the operation of ICC and ECCE, they already implanted an artificial lens after performing ICCE or ECCE on the patient. This is more practical than using this type of glasses. Now, after the surgery is done, in order to prevent the increase in intraocular pressure, we need to elevate the head of the bed at around 30 to 40 degrees. Lie on their back, avoid coughing, sneezing, bending over, or moving the head rapidly because these things can increase the ocular pressure. If there's nausea, treat nausea to prevent vomiting because vomiting will also increase the intraocular pressure. Give stool softener so that when they defecate, they will not strain during defecation or bowel movement. Or increase fiber in the diet. Advise the patient to eat foods that are rich in fiber. Report signs of increased ocular pressure or intraocular pressure, such as severe eye pain, restlessness, and increases in the pulse rate. So, post op. This is post op of ICCE and ECCE of intraocular lens implant. Prevent this from happening. So first 24 hours after surgery, the patient's still going to wear eye patch. And take note, when doing this type of surgery, ICC and ECCE, they are not going to perform the surgery on both eyes at once. One eye is going to be operated on, and the patient will wear eyeglasses during the day and eye shield at night for the first 1 to 4 weeks. Afterwards, the other eye will be operated on. So these temporary eyeglasses are worn at around 1 to 4 weeks, being fitted with permanent glasses. Cataract glasses magnify objects at around 1/3. So advise the patient that. And contact lenses causes less distortion of vision as prescribed at 1 month for ICCE or ECCE. But if there is an intraocular lens implanted, there's no need for these glasses because they are already rarely used nowadays. The intraocular lens implant is more advisable. So that's it for the first batch of eye disorders that I have discussed. So if you have any questions with regards to our lecture for today, just send me a message. I would be more than glad to answer your questions about this lesson. So again, thank you for listening to today's lecture. Have a great weekend, everyone. Bye.